Exploring Chiropractic, episode 58, Health Tech and AI with Dr. James Leonard. Welcome back to another episode of Exploring Chiropractic, the intermittently updated podcast about all things chiropractic. I'm your host, Nathan Cashin. Well, it's been a few years since I've produced an episode. My last interview was with Brian Coleman, who introduced me to the world of health informatics, this blend of healthcare and technology. And that episode, along with some other influences, prompted me to complete my master's in health informatics through Logan University. I've also kept busy with my work at World Spine Care, raising two rambunctious boys and trying not to get too out of shape. After finishing my master's degree, I reached out to James Leonard, a chiropractor I first met through World Spine Care, but who had since gained some interesting experience in direct primary care, telehealth, and most recently, artificial intelligence. Through a mixture of online learning, hackathons, and group collabs, James has created a series of interesting projects both within and outside of healthcare. In this episode, we discuss his career path, challenges with direct care models and value-based care, learning in public, and the promise of artificial intelligence in healthcare. Dr. Leonard is now a staff chiropractor with the U.S. Department of Veterans Affairs in Fredericksburg, Virginia. Now, we recorded this interview in December of 2024. It's taken me nearly a year and purchasing a new computer to be able to finish editing it, but much of the content is still relevant and very interesting. I hope you enjoy this episode with Dr. James Leonard. I guess in the interest of time, we don't have to go back and rehash everything, but obviously you're a chiropractor. You practiced for a few years in Utah, then you went to World Spine Care, which is how we met. And that unfortunately didn't go the way as planned. Maybe we start there briefly. Like, what was that experience like?
Yeah, we can touch that for sure. It was certainly a left turn that we had to take there, where we're trying to figure out how to navigate international spine care in a global pandemic. Could not have
where there already aren't enough policies, right? Like you were in the Dominican Republic. We were already just kind of shooting from the hip, I guess.
Yeah.
Just, we have an agreement there, but it's not always set in stone. And then this thing happened and it's like, crap, what do we do?
Yeah. Yeah. We did kind of what everyone else did. We tried to figure out how to exist in the new world. Which I think we're still trying to figure out how those pieces fall.
Yeah. I mean, I feel like we're only just now with World Spine Care, only just kind of getting back into the flow of things.
Yeah.
I
will say that opportunity, right? Leaving that, I didn't have a practice when I came back.
Mm-hmm.
So I had patients reaching out to me, which is where I launched that telehealth company. I mean, it was a company. I was seeing patients on telehealth trying to figure out.
And you only did that once you came back from the DR? You hadn't done that before?
Hadn't touched that before.
Oh, okay.
That was
I kind of thought you had been doing a little bit of that, yeah.
We had launched that platform before the DR, but we were using it as an onboarding and triaging platform.
Oh, okay.
So it was basically
weren't actually doing a whole
trial
of care on there.
No, the whole purpose of it was a care funnel. The whole purpose was to basically ensure get warmer leads into the clinic with patients who already were kind of pre-vetted to make sure they were going to be successful with the treatment we were doing. It's a lot easier to get buy-in at that point in time. So that's what we tried to do. I navigated that for a while and really struggled to make any real money.
Oh, really? It didn't work, huh?
It worked. I could see patients and patients would see me, but getting patients to spend out-of-pocket cash for musculoskeletal care over virtual mediums was a constant sale.
And is that because are you still talking about pre-COVID, or is this once you came back from the DR?
This is when I'm back from the DR.
Had all of the sort of exceptions been put in place to where where insurance companies and everything would allow you to do telehealth?
Yeah, you could do telehealth. But I was just cash based because I didn't have practice established. So I wasn't credentialed. in the state that I was in. So I was just doing out of pocket.
Got it.
But that experience is what took me to Crossover. I ended up meeting Dan Lord through that, because I was just looking for help. I was asking people how they make these virtual how they're making virtual care work. And that connected me to Dan, which then tied me into that Amazon project, which then unlocked a lot of things.
Yeah, Crossover is one of the companies I've just kind of had my eye on. I first heard of them because they had a contract with Apple, I believe.
Yep, that was their first contract.
Obviously, I'm a big Apple fan. And then they kind of expanded and changed a little bit, right? I think they were doing, from what I understand at Apple, was like a physical hub and spoke model clinic. And then they started doing just a bunch of different sites, mostly with Amazon. Offering some telehealth?
Kind of. So Crossover, I mean, I have a ton of respect for the company and the people involved. They started out as direct to employer on-site care, and then it just kind of developed and expanded as the markets changed. So they started doing near sites, so sort of taking on multiple employers in one central location where they were delivering care. And then now they have sort of a whole suite of products where they're doing on-site, near site, and they're also doing sort of this hybrid model of care where they're basically have a virtual overlay net for the services that they can provide virtually. Crossover is a story of just meeting customer demands. Their sales team is excellent. Their product development team is really, really good. They've just gotten really good at being able to recognize like what are the individual needs of whatever employer they're facing and how do we help them meet their desires, and changing the business to fit that. And to be honest, like your One Medicals, your Premises, like that space is really competitive. So you have to kind of be that way in order to really succeed in that direct to employer marketplace.
And so what was your experience with them? You did more in-person care.
Yeah. So I moved to Detroit because Dan Lord asked me to. So I moved to Detroit, and I just found a really supportive network there. My boss at the time, her name was Melly. She was a medical doctor, was just really, really, really supportive of my leadership journey. So first year I was on the ground. I was a provider, just a direct to patient provider. And I was really interested in sort of workflow optimization. So I got into how I could help improve the system we were building. And then I got promoted to manage the physical medicine team, so PTs and chiros. And then Melanie ended up leaving to take on another role. And in her absence, I kind of got the nod and tapped to manage the whole system. So it was 3 clinics, primary care, mental health, PT, chiro, and health coaching. So I was managing 3 clinics that were open 96 hours a week. My mental health team and my PT or my primary care team at that point were like, we had a huge mental health issue because we were managing Amazon associates. So there was a lot of mental health overlay and a lot of the problems we were managing. And they were really active. So I got pulled into sort of a lot of projects to help support our work around social determinants as a result of my role there. So I spent a year, or really 2 years, like deep diving and digging into how we can actually make social determinant screeners like functional clinically.
Yeah.
Because I was getting screener fatigue from all angles. The patients that were coming into the clinic hated our screeners. The providers I had on staff hated our screeners. So I was like, okay, well, how do we need these screeners for our HEDIS measures? How do we use the information that's coming from them to actually be useful?
And is it the number of screeners, how often they would do them, or
I think
just that there was a screener for mental health?
When people feel like they're filling out a form and that form is not going to have a purpose, they get frustrated. And I think a lot of the screens that happen in population health and in value-based care arrangements, it's not super clear to the provider or to the person filling out that information how that's going to be applicable to their condition or their problem. Right? They're in there for a headache and they're having to fill out a form about housing insecurity. And being able to make that connection is really challenging for some patients. So you have to find a way to make that meaningful to both your providers and to the patients you're managing.
So what did you find? Because that I experienced that, especially having kids and going to the pediatrician and answering these questions. Like, did you ever have trouble not feeding your kids this month or something like that?
Sure.
And fortunately for me, that's completely irrelevant. Like, that's just never been a problem and probably won't be for a long, long time. But I have to fill that out, and I have to fill it out every visit. And so I get that, why that's frustrating and fatiguing and just annoying. Like, can I just click a box that says I don't need to do this until? So I'm just curious, from kind of the user experience perspective, anything you might have learned?
Yeah, I mean, I think this is one of the rubs in the modern sort of value-based care, like population health philosophy of like the way we're currently thinking about delivering care. I think that's one of the big rubs that's happening right now. I don't think there's a perfect system for it. But what we really wanted to do, and what we did was we wanted to go back to the data to see how are these screeners that we're giving, how are they connected to outcomes? How are they connected to the amount of time that a patient is spending in care? How are they connected to engagement? Because we're direct to employer in that space, right? So engagement's really important. We need to be actively managing this population that we're being paid to manage. So our first step, and I'm very fortunate, I got partnered with some really amazing people. Carter Comrie, who was my mental health lead at that time. And I also got partnered really closely with our DSA team, our data analytics team. So Michael Jensen was the one who ran the sort of data side of the equation. And really we just looked for clues in the data to see which screeners were most significantly connected to our outcomes, our engagement, and sort of that patient life cycle and care. But then we also looked at what happens when we group certain screeners together. And do we need to look at each screener individually, or we can look at them sort of more as like parts of a whole, right? If someone is suffering from housing instability, most likely they're going to have food insecurity as well. Like those two are oftentimes co-connected. And what we found is you could really divide things into two groups. You had individuals that screened for greater than 3 and individuals that screened for 2 or less. And the individuals that screened for greater than 3, those are basically the patients that are coming into our system on fire. They're really having a lot of problems in their regular life. They're having all those health-related social needs. And those are the individuals that actually like our conventional healthcare system, our conventional integrated healthcare system more so. So we've got kind of all the parts you need. Those are the ones that like that system can really help because they engage actively in care. And when they're engaged in care, they get great outcomes. It's like putting a fire out, right? It's pretty predictable. You can like really work someone through that course of care. And those are the people that really like end up succeeding in improving the most from an outcomes perspective. Being able to shine light on that and then take that information back to my primary care team, it seemed to lengthen our rope a little bit, but it also really solidified the referral process. Like a lot of times, especially in that integrated care system, those referrals, there's an element of sales that comes with it, right? Like the primary care provider or the referring provider has to really believe in the referral that they're giving. And they have to really believe in the person they're referring to. And when you can go back to that group with data and say, hey, here, like when we refer this patient population that's on fire, they actually do really well with our care. There's more conviction around that referral. So it ends up becoming there's a lot less friction around making it. However, that is for sort of our high risk, high acuity patients. To answer your question, that's not everybody. Like a lot of individuals are just engaging in care because they have a specific problem. And we don't have an alternative healthcare system for that patient population in the US. I mean, I guess we do. I guess it's the cash paid system.
Right.
Right.
Yeah.
But the current system as it's set up isn't really designed to manage that patient population who's sort of sub-symptomatic and just looking to optimize their health.
Yeah, there's somewhat of a gap there because I was just reading about a review of Peter, who recently came out with a book on longevity, and he has kind of high-end clientele. His patients pay, the estimate is, he hasn't revealed this, but the estimate is like $150,000 a year to get direct care out of pocket, right? And they're doing stuff that, it's not like they've got some serious health condition. They're trying to prevent anything from happening in the next 50 years. So that's like one extreme. And then as you were talking about, people with housing instability and all of these other, whether it's low income, like we see in the DR and all that kind of stuff, like that's where our health system seems to focus, but there's a lot of room in between there that there doesn't seem to be really any solution.
Well,
Just
there's a lot of gray there, right? It's a difficult place to navigate, because you look at the individuals who have uh, episodic back pain, right? Like they generally would fall into that space where it's like, hey, like every couple months my back hurts and it's disabling when it hurts and it makes like doing regular life really challenging. And then I engage with care and it gets a little bit better. And then I'm able to kind of go back into my normal function. And our healthcare system doesn't like, or isn't set up to really acknowledge and absorb those patients, because if you did every scan on the world about for that patient, it's going to unveil either nothing, or it's going to unveil a bunch of pathology that may not totally be contributing to their symptoms. Right? You look at the prevalence of asymptomatic normals, and we don't like that. That's a tough answer to give patients when it's like, sometimes backs hurt, and when it does, like this is how you manage it. Like I can help you work through that process, and we don't have to throw all of the interventions in the world at you in order to address that. And I think the DPC world, so PRT is like a really high end direct primary care outlet. Like the DPC world and longevity medicine is really, I'm in a lot of conversations in that space because I still have sort of ties into the primary care world, especially through a lot of my tech projects. It seems to be like that is the new flavor of the month, is this working into these sort of subscription models that help to subsidize a lot of the long-term care. But as a result, it's like a really great customer experience that you can engage with when you want to. And the provider, their incentives are totally aligned to sort of like, how do we help you long-term navigate this health condition?
Yeah, it'll be interesting to see what can be learned from that. Obviously, it's way out of reach for most people. But I'm glad that people are attempting it. There's so much we can talk about here. I want to talk a little bit more about the telehealth experience, but you mentioned the data analysis that you dug into at Crossover, and I'm curious what that looked like. And we can get quite technical and specific, because this is what I'm very curious about right now, is like, okay, how did you analyze that data, and what things did you have to learn to be able to do that?
Yeah. So this is a space I spent a lot of time is trying to figure out what my role in any individual team is going to be. In that particular instance, the data analytics was not my responsibility. So I was more on the clinical end. My role in that situation was really being able to help identify and understand what questions we should be asking, and then being able to take the data that was interpreted through our data analytics team and then be able to communicate that back to our provider team in a way to actually change behavior and improve behavior. So in that particular instance, I was not doing the hard work, although I was putting ones and zeros into a spreadsheet there for a couple weeks. That wasn't really the actual analytics process wasn't really under.
So you weren't doing the computation.
No.
Do you have a sense for what that looked like, what tools they might have used? Or did they just give you kind of the end report?
Yeah, I was really more along the lines of just having the conversations as it was unveiling. I can't remember exactly what tools we were using. I was involved, at least I was sitting in on the meetings during those conversations. But to be totally honest, it was a bit over my head as we were working through it.
Yeah. Well, that's fine, because there's still so much to learn just about, even once you have that, how do you look at that? And again, like, what questions are you asking? And how does the data answer that? And I just I think this is just often referred to generally as data literacy, right? How do you look at data, whether it's the end reports or the raw data, and how do you make decisions from that?
Yeah, and I think that's something we're facing more and more. It's actually something I've really been honing in on and thinking about and reflecting on when it comes to using AI tools in healthcare. Is I think there is an element of literacy when it comes to using data and using these technical tools in order just to be able to solve problems that you see in the wild, right? Like I find that clinicians or folks, a lot of the individuals I get to interact with on the innovation spectrum and in sort of the startup landscape, they there's a tendency to fall into one or two camps, and that is like these tools and this data can tell us everything that we want to know, and therefore we should totally rely on it. It's absolutely important. And then there's this other camp that says like, that's kind of useless. It's not actually existing in the real world. And like most things in life, the real answer comes somewhere in the middle, and
Mm-hmm.
it's a matter of like, if you have really bad data, you're not going to be able to make good inferences off of it. Like if your data collection processes aren't great, you're not going to be able to make good inferences off of it. And the same way that if you have really amazing data that gives like very clear direction and very clear lines, but you don't have the capability of executing on what it's telling you, or you don't have the ability to like work your system or motivate the people in your system to be able to enact what that data is telling you, like it's also not as valuable as it could be.
Yeah, we're at this inflection point where AI is so exciting that people are trying to do everything with it. I think it's both overrated and underrated. Overrated in the short term, where people are like, "Oh, this is the solution to whichever problem they're trying to pick." But I think in the long run, it's just going to, we're going to be using it side by side with our own decision making, and it's going to play a big role. But it's not going to be kind of a one. Uh, I just watched Lord of the Rings last night. It's not going to be one ring to rule them all.
I
Right? It's going to be a bunch of little rings that we kind of put in various places.
I'm actually rereading the Lord of the Rings right now, so I'm having a good time with that one. but I agree with that. But I think the point you made earlier about literacy is really what matters. Like at the end of the day, integrating data and integrating automation tools. So right, AI just speeds up processing of whatever you're trying to do, whatever predictable workflow you are doing. AI is just going to enhance the efficiency of that.
Yeah.
If your workflow is bad, if your workflow is not serving the end user well, like if you make it more efficient, it's not going to serve them better. it's not it's not going to serve them better. So it's a matter of, I find that to be one of the more useful skills, at least in the people that I really admire and I think are really doing an amazing job right now on in applying these technologies. Like that's a lot of the way that they frame their thinking around it is like, hey, I just want to be extremely literate in the use of these tools and in the use of data and from a decision making perspective. Like it's like a learning a language, right? I want to become a native speaker, therefore I have to learn about it, and then I also have to practice it in the real world. And through that, you start to get better and better and better at recognizing what should be measured, and then recognizing sort of what are the common problems that or the common, what are the really common and predictable barriers that I hit, and that I have to like hit this key or like type this message in order to overcome it. And then
Right.
how do I make that, like this tool would be a great way to make that more efficient.
So share how you've done that. You introduced me to building your own GPT models. You created Joy or Recess, this kind of activity guide. And then you've done some stuff with radiology. How did you go about it? Did you take a course? Did you just start playing with it? How did you get to where you actually have these viable prototypes?
Things that exist in the wild.
Mm-hmm.
I had to learn how to take my ideas and present them into the wild. There's just no easier time to learn than right now. Um, November 2022, right? ChatGPT goes into the wild and becomes accessible for everyone to use and to just experiment with. I just got totally bit by that bug and started trying to figure out what can I use this for and how can I use it to solve my everyday problems. And then that journey has kind of led through these stages of like learning and development and then deploying. So there's a lot of ways to do that and a lot of places to learn. A few resources that I've been using. Deeplearning.ai is a really, really
Okay.
excellent resource if you want to learn like elementary coding, specifically tied into how to incorporate AI and tie together APIs to be able to accomplish individual tasks. Um, you can learn some really elementary Python through that. And if you learn Python, you can learn how to use APIs. And if you learn how to do that, you can learn how to build things to solve your own problems. I've been just a part of like a bunch of really, really active and helpful online communities. I found X.PC. So X equals primary care is a group. They run a work group called Clinicians Who Code. Andrew Hines, who is the CEO of Canvas, runs that. And I learned a ton through there just about like how to develop really basic like coding in order to be able to accomplish tasks.
And this is the Canvas EMR platform, right?
Yeah. And then I've just done a lot. I've engaged in like a lot of competitions, so hackathons. Um, and those hackathons are just a really great experience to be able to sort of dive deeply into like a learning experience. Like you go in with nothing and then develop an idea like with a group. So there's a big group dynamics element. You develop an idea with a group and then you have to execute and build in that weekend. And that sort of process, I find that evolving process, especially in the conversations I'm having more in software development and working with, I'm advising a few different startups, and I've been working a lot with individuals who are like really building and trying to transform, like bring their ideas into life. I find that it's not a linear path. Instead, it's very much, okay, I'm going to go study, I'm going to go learn, I'm going to go inward and try and figure out, okay, what are the problems I want to solve and what skills do I need to solve those problems? And you develop that, and then you can go out into the wild and then you try and deploy it. And through deploying, you learn a lot. And then every time I kind of go through one of these processes, I end up with a whole bunch of new skill sets, and it makes me way better at solving the next problem or way more useful when it comes to solving the next problem. The radiology tool is an interesting one. I had the opportunity to build that out of pocket. Out of Pocket is a Slack group and Slack community and newsletter run by Nikhil. He's really big on LinkedIn. He's a funny cat. I learned a lot at that hackathon, but that experience and deploying that at the hackathon has now led to an opportunity within the VA where we are still in the pitching element of it, but trying to explore if it's possible and what that would look like to deploy like a similar style platform within like a really large healthcare ecosystem.
Yeah, I love this thing you did. So you used large language models, right, to essentially rewrite radiology reports into plain language so that patients could understand them.
Yeah,
Right.
essentially.
And this is the idea is that this would be integrated within their EHR so that the doctor would get the radiology report and could choose to summarize it and then send it to the patient.
Yeah. Well, and that's the really interesting or fun part about that tool, right? Providers don't need another external tool where they have to extract information, put it in, process, and then pull information from there and put it back in. So we knew that if we were going to build something useful, it was going to have to be totally embedded in the system that we were using. And I learned that I was on the clinical council for an ambient dictation company called Abridge. They're doing amazing. They're amazing people out there. They're certainly one of the market leaders in that space. But I had the chance to demo and work with their product kind of early on. And I just witnessed that myself, that if it wasn't embedded when I was working with it. So I had to really be a motivated user in order to like take the information from it and then pull it over. They've since embedded with Epic, and I think they're really doing amazing work there. But for us in that particular competition or in particular use case, we had the opportunity to work with Canvas. And Canvas is the thing they're really priding themselves on as an EHR is they make it extremely simple to build on top of their platform. So any workflow that you want to put together, they'll basically make it so that you can embed it in their process and in their system and be able to execute that on their EHR platform. They call it care modeling, and it's something that really I've gotten to know them pretty well over the past couple years. I really admire the group over there, and it's something they're doing more and more of. Is basically how do we design our EHR so that it's really specific to whatever problems you're trying to solve in the healthcare marketplace.
Yeah, Canvas looks so interesting. I'm very curious to follow it and see where it goes, because this idea of sort of customizing an EHR um, has been such a challenge, because I think all EHRs suck because they try to do it for everybody,
Mm,
right?
yeah.
Even within, say, chiropractic or musculoskeletal care, like they're still trying to do so much, but to customize it takes some skill, and not every clinic is going to be able to do it, right?
Yeah, and not everyone
But
has the support staff to be able to do it, right? Like not everyone has
yeah,
the overhead to be able to support an internal DSA team. Like so you have to be able to it has to be customizable to you, but it also has to be extremely user friendly.
yeah.
Um,
So I like this modular approach they're doing. That's very interesting. I know we're running short on time, but we've touched on a lot of what I wanted to bring up, and really, the crux of it is having just finished a master's in health informatics. Um, over about the same period of time, right? I started in August of 2022, so right before ChatGPT was released to the public. And I remember using it on one of my first papers and kind of being like, just as an experiment. I obviously did not turn that in, but I was like, let's see what this thing does. And so I've kind of been keeping an eye on you over LinkedIn and social media, and you've done so much. And it feels to me, a lot of people go back to school and get a master's where they could just be working on some projects. Um, and I'm just still trying to understand the difference and the benefits of each for myself. But I'm curious what your thoughts are, kind of, doing it for a couple of years and being where you're at now.
I think there's a space for both, right? I think it's a matter of your learning style. I think that's one of the most interesting things about like this modern age of tooling. Like you can really customize your education to how you learn best. And at the end of the day, it doesn't matter what your credentials are. It matters how effective you are at solving the problem you're trying to solve. Can you do it at scale? And can you do it in a way that like meaningfully makes a difference to the people you're trying to serve? Um, and for me, like I'm very much so a hands-on learner. I listen to all of my lectures on a bike. I have a bunch of bikes back
Hmm.
here, but I can my information retaining, like I need to be moving in order to be really retaining like information. So the traditional classroom experience isn't a great fit for my learning style. And to be honest, I've looked for programs that I felt like were going to help me develop the skill set that I wanted to develop, which was to essentially be a total native speaker with these AI tools in the world of healthcare. Um, and there just wasn't one available. I think they're still writing the curriculum for it. Um,
Yeah, I mean, you got to kind of piece it together on your own.
However,
Um,
in your situation, which I think is like the other side of that coin, right now that you've gone and taken that actual, you've done a postgraduate master's program, you've now laid like a really excellent foundation in informatics. So like you in data processing and understanding sort of the world of data analytics. Now, when you go and apply yourself in this, like in sort of run this gauntlet, you're going to have this totally different skill set that's going to be really, really, really valuable.
yeah, I'm still trying to decide, or just kind of process whether I feel like it was the value I was hoping for. I think my particular program probably is better for, say, someone in a nursing or, therapist position who's already involved in some health informatics and maybe needs the credential for a promotion. Um, I had kind of a very wide open goal, and at the end of it, I certainly learned a lot, and it's given me a little bit more confidence, but I don't feel it gave me the opportunity to develop the skills. Even though I took the data analytics track, I had one class on Python.
Yeah.
And previously, I'd been trying to do data camp to learn Python. And I think I've probably learned just a little bit more in the course because you're kind of pushed within 14 weeks to get to a certain point. Um, and to me, this is the big difference. Is like if you are self-driven and have the time, I think that was my problem. I was trying to do data camp for about a year, but it's just finding the time. Um, Once you have invested, $3,000 a trimester in this master's program, it's like, yeah, you're going to make the time for it. And so that's the balance for me. But it certainly seems like getting involved in a project has probably a quicker return on developing those skills.
It's learning a language, right? It's a programming language, and it's the same way as if you were trying to learn Spanish to go serve for a nonprofit in the Dominican Republic.
Exactly. Yeah. The immersion, the immersion certainly works better. The question is like, how do you immerse yourself? It's kind of like trying to immerse yourself in a language, but you're not in the country and you
Yeah.
can't find the community. So it's like,
The
how do I
two,
even know where to start? Like, what words am I even looking for?
yeah. So there's two. I think this is actually something that I've really noodled on for the past couple of years. And there's two camps that I think, once again, we've got our two camps where things fall. There is, I really enjoy the community, like competition aspect. I was an athlete my whole life. So finding these competitions and then just throwing your name in the hat, like you basically just apply to join and be able to be a part of them. Once you do one, it becomes a lot easier to do a lot of them because you just start getting invited to a lot of them. My group won the first one that we ever did. And that one led to like 4 or 5 different competitions that have now led to basically just the sport of innovation. And once you're sort of in the circuit for it, like it's pretty easy to stay in the circuit because you just start getting invited to things.
Mm-hmm.
But it's all on the weekends. Like these things all happen at night. They all happen at the weekends. It's not a job. This is all, everyone else is doing something else. This is a skill development thing. I think the next evolution after that is being able to find and identify core problems in the patient population or in whatever thing you are trying to solve. Like what is like core disconnects that you run into? What is the thing? And this is the skill that I've been really working on developing for the past couple of years. And it's one of the things that made me really interested to come back to a role where I was just doing the work. Right now, I'm a clinician in the VA. I've got to run here in a minute because I've got to go see a patient. But when you're engaging and doing the work, but you are literate with the tooling to make all the work really efficient, you start to see disconnects. You're like, there's a better way to do that particular thing. And that's where the radiology tool came from. That idea came from, I'm in the VA. I have a patient population with a high propensity for mental health comorbidities. And because of the 21st Century CARES Act, right, every single radiology report gets released to the provider and the patient at exactly the same time. But there's a natural lag in the system where that patient's not going to be able to access their provider for probably 3 weeks, maybe 4 weeks after they get those results. So by the time they get to that provider, they've already made up their mind about their condition and how bad or how unhelpable they are.
They've visited Reddit and asked strangers on the internet for their interpretation.
Solve that problem over and over and over again. And I was like, okay, there's probably a more efficient way to do this. Like, what if we provided context with the issue that's coming through? And I looked at like, okay, well, who's done that? So Blue Cross Blue Shield and Excellus, Brian Justice up in Western New York, right? They ran the project where they were sending epidemiological information attached to the imaging reports to the patients. So ran a huge study on that. There was also the LIRE study, LIRE, which was funded by the NIH. Kaiser, it was mostly run at Kaiser facilities where they did basically the same thing. And they had pretty modest outcomes doing that when they would just sort of attach these epidemiological problems to it. So I'm thinking, I'm sitting there, I'm having conversations with other providers around me, and it's like, Okay, why doesn't that work? We just gave the patients all the information. We said, hey, you've got degenerative disc disease, but it's okay because so does everyone else.
Hmm.
And it didn't feel like that actually clinically made a significant difference in their care. So it's like, okay, so we have to do a little better than that. What can these AI tools do that we previously couldn't do? And so, well, they can make things feel personal. They can pull in and extract other data from your chart, extract other data about you, and then deliver that same information, but in a way that it feels like your provider is interacting with it. And at the end of the day, that's exactly what's happening, right? Because in this particular workflow, the provider will go and review that information and will then like decide what stays in and what doesn't stay in and send that as a personalized message. But there's like opportunities like that everywhere in healthcare where there's like these little inefficiencies or little rituals in the system that don't make any sense. And getting better, and that's the people who I really admire and the skill that I'm looking to continue to develop is getting better and better and better at recognizing like where are those problems and what are the more useful ones to solve for patients.
Yeah. This is awesome. We could talk for quite a bit longer, and I've got a few ideas I'd love to run by you as well. But I'll let you get back to your clinical duties, and we'll have another chat hopefully sometime soon.
Yeah, I'd love to. I'd love to continue to hear more about how you apply what you learned in that informatics program. It's great that you
Yeah, we'll see
continue.
how it goes. I'm trying to again make time to do something like data camp or some of these other online programs
The,
because they're certainly much more affordable. I was about to do an elective in machine learning.
there's
And then I realized, gosh, $1,200 I could pay for data camp for 4 years.
there are so many free resources out there right now.
Yeah.
Deeplearning.ai is a really excellent place to start. They just released a new Python for beginners program probably a month ago. It will teach you everything you need to know up to the point of being able to strap and tie APIs together, which
Cool.
is a really great place to be if you want to start building.
I'll check that out.
Cool.
All right. Well, you got to get back to clinic. I've got to jump over to the Apple announcement on their new phones. I don't know if there's going to be much AI in that.
I'll talk to you
But
soon.
I'm excited to see. All right. Thanks, James. Have a good day. Thanks for listening to this episode of Exploring Chiropractic. If you enjoyed this different topics of health informatics, technology, artificial intelligence, I'd love to hear, because I would consider doing more episodes or even a new podcast on this type of content that's relevant to chiropractors and musculoskeletal providers. So if it resonated with you, if you were interested in the things that we discussed, send me a message on social media at Exploring Chiro. Visit the website exploringchiropractic.com and leave a comment on this episode page. Or send me an email, nathan@exploringchiropractic.com. I look forward to hearing from you.